So I'm excited to be here. I'm Scott Wieters. I'm going to talk to you guys about presenting presentations, how to do it well. I am from Scott & White. We're a big hospital in a small area. I love my job. I get to meet some of the most amazing medical students in the world. I get to practice cutting-edge medicine, and I get a big city job, but I live in a small town. I got the best of both worlds. So this is a shift I was coming into. We've got 8 ambulances meeting me as I walk into my shift, so we're a pretty busy place. We see about 100,000 adults in our ER, and we see about 30,000 kids in our specialty pediatrics hospital. I don't have conflicts of interest, but I'm always looking for one. So if you got an idea, I'm your man. I'm a little jealous. I've talked to you guys, and I'm excited because I think you're in a really cool stage of life. I mean, right now you're finding out who your spouse is going to be. You're figuring out your specialty. You're figuring out what you want to do in life. And this is a formative time. And I think back to this time when I was in medical school. San Antonio people, where is this? Breezeway, right there. White coat ceremony circa 1997. I'm dating myself. This is one of my most prized photos. Both parents, both grandparents. It's the only photo I have ever. It's a fun time. I'm excited for you guys. So, what are we going to do? The clerkship. I remember going to my clerkship, and it's kind of like you're under the microscope, right? Dr. Vandermark was talking about everything you do is part of the interview. So you got to nail it. Everybody's looking at you under a microscope. And it's kind of like high school, right? It's awkward. You're showing up, the suit doesn't fit right, there's this beautiful girl you want to impress, you know, her parents are there, you're not in your own home. It's just awkward on so many levels, right? You want to bring this beautiful little flower, this presentation, and show her how wonderful she is and how much you love her. And sometimes it doesn't look good, right? So, what are we going to do? This is how most people show up at their clerkship, right? You don't want to be the deer in the headlights, right? Because when you show up like a deer in the headlights and you don't know what the heck's going on, a lot of times animal instincts take over. So, if we're not prepared, we tend to do things like animal instincts. We fight or we flight. So you might try to make yourself look bigger like some animals do, right? And you're all tough and this and that. And it might come across usually as something like this.
Well, Dick, here's the deal. I'm the best there is, plain and simple. I mean, I wake up in the morning, I piss excellence, and nobody can hang with my stuff. You know, I'm just a big, hairy American winning machine. If you ain't first, you're last. You know what I'm talking about? That phrase is trademark, not to use that position to Ricky Bobby.
Yeah. So you overcompensate, right? And it comes off as an arrogant jackass. I'm sorry. So, what do we do? Right now, I hope I'm not scaring you. I hope I'm putting in a little bit of healthy concern and some healthy fear. But I will say that you guys are doing a good job of showing up prepared. The fact that you stepped in this room, the fact that you drove from your home to come to this conference, you're showing up prepared. All right? Listen to the goodness here. I mean, this is a big plate of like gravy with sausage in it, and you guys like a biscuit. Just sop it up and just take it all in. I mean, it's good. So pay attention to the people in the back of the room. Pay attention to the people that are talking up here. Ask the good questions. Use the panel discussion. Figure this out. Dialogue. You guys are preparing, okay? Because that's not the first time this crew hit the beach. It's not the first time that they put this equipment on. And it's not the first time that they organize their approach. You need to do the same thing as students. First impressions are huge, right? Because the first impression is really the truth. You guys meet somebody, you know within a few seconds, are they serious or not? The rest that follows is just the excuse of memory. Some of you make good first impressions and others don't, okay? But hopefully after listening to this, or after working through things, you're going to make a great first impression. How are we going to do this? The first impression is going to be your presentation, okay? That is your first impression. I'm going to talk to you about how to polish them and what we want as a perfect presentation. You've got to prepare for procedures. I talked about that, right? That's not the first time that crew went to the beach. Hopefully it's not the first time you've ever put a laryngoscope in your hand is right in front of a patient. You've got to prepare. I'm going to talk about the positioning. You've got to put yourself in the right place for the right time, right? You can't be back checking SportsCenter highlights and you're going to miss the code. You've got to position yourself. You've got to have patient ownership. It's all about the patients. It's not about you. It's not about me. It's about the patients. So you got to take ownership of it. You got to own that person. You got to be there and be their doctor, not their student. Participate. There's always an old lady that needs a blanket. There's always some old dude with his wife that needs a cup of coffee. I mean, you can always do something. There is never an excuse to sit there and say, hey, nothing's going on in the ER. Go find something to do, find a way to help, learn from a nurse, learn from a paramedic. Take advantage. This is an amazing opportunity. You guys have an opportunity to see and learn from. And then practice. You got to practice being an active learner, okay? You want good feedback? You got to go get it. I just finished my shift. I know we saw this patient with chest pain. How was my presentation? I want to do better. Help me understand how to do that. You've got to go get it. So let's move forward here. What is the EM presentation philosophy? Let's start. I love philosophy. If I had a chance to do it over again, I wouldn't have wasted my time doing science. I would have become an economist or a philosopher or something like that. I'd still be a doctor, but I love philosophy. So what's the EM philosophy? How are we different than somebody else? Tell me real quick. What do we like at a presentation that's different? I heard fast, yeah. I don't have time for like the whole 1 hour long internal medicine presentation. I'm going to fall asleep or go off and do something else. We care about the dangerous stuff, not the benign. You come to me with gastroenteritis, I'm going to tell you, go back and get a better history. You've got to think about other stuff first. So what I did to understand better about the EM presentation philosophy, I called a bunch of my friends. I talked to every single clerkship director in the state, sent him some emails. I'm like, hey, shoot me a video, shoot me a 10-second blurb. What do you want the perfect presentation to be? And I'll show you what I got. It's interesting. Mike Parsa out at Texas Tech, right? So Mike says, if it's too long, we stop paying attention, right? It's got to be quick. Keep it short and relevant. Don't present every detail. You are no longer a reporter. If we want you to expand on something, we'll ask you. All right? He likes it short. Drew's one of my partners up at A&M, so here's what Drew thinks about it.
Look, you're not a voice recorder. You've passed third year. I don't care about the history. I don't care about the information I collect myself. I want what you think the patient has and what you're going to do about it. 2 sentences. That's it. Now get to work.
Drew works the night shifts. He's busy. He's got 50 beds he's responsible for. He doesn't have time for this long internal medicine series. He wants 2 sentences, short, sweet. That's what he wants. All right, Mike Van Meter, one of my favorite guys out in Houston. Mike's got some goodness. Are you ready for this?
This, which is the 3-minute emergency medicine medical student presentation, a variation on a theme. And if I could focus on one thing, it would really be your transition from role of reporter to that of interpreter. Meaning, don't just regurgitate what the patient tells you, but bring us a narrative that is clean and concise and leads us straight to what you ultimately think the diagnosis is.
Yeah, if you want one paper to read when you leave here and you want to do a good presentation, check this out. All right? Google 3-minute emergency medicine medical student presentation. This is goodness. This is high yield stuff right there. So you're no longer the reporter, okay? In med school, they asked you to ask all these questions. You lined them up and you said, okay, now I'm supposed to ask you about your toenails. And then do you have rashes? Like, bro, it's my ankle. Oh, I understand, but have you had any kind of heat intolerance? Like, my ankle's crooked. I don't care, okay? So you got to sort through the mess. You can't bring all that nonsense to the table. We don't want it. You've got to move to the interpreter. That's the next level that we need to shoot for. Kim Leeson, love Kim. She's down in Corpus Christi. Here's some goodness from Dr. Leeson. Let's pay attention.
In my opinion, medical student presentations should always start with a great opening line, such as, Mr. John Smith is in room 10, he's here with chest pain, and he has a history of diabetes and hypertension. Students should strive to always make their presentations short, sweet, and to the point.
That's where it's at, right? The one-liner. Okay, I'm not talking about this one-liner.
Did it hurt when you fell from heaven?
A little.
I'm sorry, I have to go.
Oh, okay.
Don't bring that to Dr. Leeson. She's likely to slap you down. What am I talking about? Here's my one-liner. I've got a guy with abdominal pain. I'm worried about appendicitis. Can I tell you some more about him? Okay. I just saw a kid with gastroenteritis who's got vomiting and diarrhea. I really think things are going to be okay, but I want to run it by you to see if there's something I'm missing. You see how that works? Start with a one-liner that communicates what you think is going on with the patient, what you think might need to happen, and where you want to go. It might be, I want you to come look at the guy in bed 1. He's sweaty, diaphoretic, and his sat probe's not picking up. Walk with me as I go get the crash cart, okay? I'm serious. That's the way it should go. So that's the one-liner. I love it. All right, you just heard from Dr. Vandermark. I got him to load down some goodness. If I could point out the dogs playing poker statue at the top of the screen there in the back of his cabinet. Be sure to ask about that at interviews.
I think one of the critical things in the perfect medical student presentation is social history. When there's less wrong with you medically, social history becomes critically important. Thanks.
Yeah. In emergency medicine, the social history really is going to determine can they go home or not. You live 30 minutes from the hospital and your wife's a nurse, yeah, we can take care of you. You're fine, okay? Well, you're homeless and live 3 hours away and you're 90 years old and you can't walk, probably need to stay with us tonight, all right? Can you afford the medicines? Do you have a doctor that loves you? So these are important things that are going to be a big deal. One of our newest clerkship directors, all right, we got Adam Jennings up at JPS representing. So I caught Adam last night. I got a quick blurt from him. The perfect presentation should be the true reason for somebody being there. And it's better even if you can glean it from the history. Okay? Gosh, you got this kid with a fever. It's 2 a.m., lady. Come on, this kid's fine. What are you here for? Well, my older son died with very similar presentations to this 2 years ago, and I'm kind of scared. Oh, well, that's kind of a very different thing that I need to know. Thank you. Yeah, if you can find out what people want, what they need, they might have a very different trajectory for why they're in the emergency department, and you're missing it completely. Find out what they want and why they're there. All right, my San Antonio people. So Dr. King here is going to talk about some things, a little more cerebral approach, and it's going to kind of translate into the next part of the talk. Let's see what he says.
For me, the perfect medical student presentation is that in which you can encapsulate the patient's problem and explain to me your decision making. Why do you think certain parts of that history and physical are more important than others, and how it's driving you towards a particular diagnosis or set of diagnoses?
Exactly. So there it is, right? Dr. King wanted to know really how we're thinking. Tell me what you're thinking. If you don't say and communicate aortic dissection, I don't even know if you know that thing exists. Okay? So you got to let us know what you're thinking. Patients give us a big blur of information, and we've got to come out with a clear HPI. Okay? You've got to sort out the noise and take that filter and really give us something we can work with. Okay? Make it concise. Filter that out. Don't just report the news. The review of systems is not a list. Again, you're not going to go down the list and start asking everything just because you're asking questions. Okay? Instead of review of systems, think about the review of systems as a differential diagnosis. The way to remember that is ROS no longer in your mind should be review of systems. It should be rule out serious. How does that look? What if I told you I've got a patient that's got chest pain and I say, well, in review of systems, there's no unilateral leg swelling, hemoptysis, or pleuritic component to the pain. What am I asking or telling them that I'm thinking of? PE, right? I've just told you I thought about PE. Okay? Got a headache, and by the way, on review of systems, there's no vision changes, unilateral eye pain. Okay? What am I talking about? I'm thinking about glaucoma or something like that, right? So I am telling you that I'm considering these things all within the way I report my review of systems. Do you see how that flows? All right. The next part, we've done an HPI. It's concise. We've given a great one-liner. We've included the social history. We've gone through a review of systems that has pointed out the differential diagnosis. Next, the vital signs are vital, okay? And it's always important to say something about the vital signs. You can say the vital signs are normal. I always like that if they're short of breath, you say, by the way, the nurse wrote down 20 for respirations, because nurses always write down 20 for respirations. But when I was in the room, there were 32. I counted them myself. Oh, okay. That's actually a pretty good way to say it. The next, you got to find out if they're sick or not sick, right? Is this guy rolling around like he's a soccer player? Or is he trying to tough it out because he's a hockey player? Okay? So the vital signs are normal, and by the way, this person doesn't look sick, Dr. Wieters. Okay. I've actually got 2 minutes. I can listen now. Versus, this person's dying. Let's go now. Sick or not sick is a big important thing that you need to be able to recognize. You got to have that blink read from across the room, and as you get better, as you see more patients, as you become experts, you'll be able to better discern who's sick and who's not sick. Your exam, just like the review of systems, should also be a list of a differential diagnosis. If I've got somebody with abdominal pain, and I come up and I say they've got no pain at McBurney's point, they have a negative psoas, a negative obturator sign. What did I just say that I'm considering in my differential diagnosis? Appendicitis, right? Okay? You're communicating the way you're thinking by specifically saying things. Don't come to me with no murmurs, rubs, or gallops, regular rate rhythm. What the hell is that? I've never heard a rub. I'm sorry, it just doesn't happen in the ear. And I don't care if they've got a rub. Now, maybe you've heard some pectoriliquy or something like that, and that's beautiful sounding, but none of this four-bowel sound quadrant nonsense. Is this a surgical abdomen or not? Okay? So communicate using terms that will lead us to understand your differential diagnosis. I can't believe this guy's palpating with the groin with no gloves. Who's on Google doing this? It's disgusting. Use some gloves. Medical decision making, right? You got to think about the worst case scenario. If your top 3 diagnosis for a kid with a fever is virus, cold, or rhinovirus, I don't know, okay? Don't come to me with a 90-year-old thinking your top diagnosis is constipation. M&M cases are built on things like this, okay? Worst case scenario, I want the killers for every chief complaint. There's only about 5 or 6, maybe a dozen, but you need to know these for every chief complaint. After I've considered everything else, yeah, maybe it's a virus, I don't know. But you've got to think about the worst first. Also, you need to make a decision. There's nothing worse than hearing some student do an amazing presentation, and at the end, you're like, well, what do you think we need to do with this guy? Like, well, I don't know. We could send him home. We could admit him. Maybe I'll get a CAT scan. I don't know. Maybe a CBC and see what happens. I don't know. What do you think? No, don't be the wet noodle, all right? Commit, okay? Make a decision, man. That's what MDM stands for. You got it? So, how do we do that? We've got to commit with humility, okay? Nobody wants the arrogant student that's like, there's nothing wrong with this guy. He's fine. Send him home. That doesn't sound good, does it? No. How do you humbly commit? Okay, here's how you humbly commit. This person's climbing. They're reaching for that next level. They're taking a risky move, right? So you got to reach out. You got to take some risk. You got to grab on. But it's with humility. You bring the rope, okay? You're wearing the rope. How does that happen? Dr. Wieters, I may be wrong about this. I'm only a medical student, but I think with this guy's symptoms and his EKG changes, he probably needs to be, admitted for an ACS rule out. Okay. This kid with the vomiting and diarrhea, I looked him over really good, and I'm trying to find some bad things wrong with him, and I might be wrong. I hope nothing more serious is wrong, but I think it's just a virus. Could you come check him to make sure I know what I'm doing? Do you see how I've done that? I've made a commitment, but I've seasoned it with some humility. Okay? Don't jump in like the tiger. Don't be the bull in the china cabinet. Come in with humility, but make a commitment. Some of the things we say can come across aggressive. Some can come across conservative. And I think everybody wants to start off, and I see this continual theme, that you want to make yourself sound like you've seen a lot of patients, that you're experienced, that you're knowledgeable, that you've seen some sick patients, right? Because everybody wants that to be known about them. You want to be respected. So it comes across as, I've seen a lot of sick people. I think they're just fine. I don't think there's anything wrong with this guy. Maybe this guy's just a drug seeker, right? That's it. Yeah, I'm good at detecting drug seekers in my experience because we got a lot of drug seekers where I come from. We don't need to admit this guy. I've seen sicker than that before. We don't need to scan this guy. I don't think it's anything bad, okay? You're trying to make yourself appear like you know more than you know. And it usually comes across as aggressive, dismissive, and arrogant. Okay? So how do we change that? Everybody think of where you are right now, okay? And I want you to take a step towards this side. Here's how you do it. Well, they're probably just fine, but I really am concerned about the patient. Okay? And they might be a drug seeker, but maybe we should take him seriously for 5 minutes and really spend some more time figuring this out. How about instead of, we don't need to admit them, well, I've heard this can be kind of bad. Elderly abdominal pain has a high mortality, so maybe we do need to work up, maybe. And maybe the safest approach, even though I don't think it's anything bad, is, well, maybe we should, do a workup here. So these are the ways that you can season your words so that you don't come across as the arrogant, know-it-all jerk that's at the bottom half of that slow. Because I'm telling you right now, it ain't the grades that's going to kill you. It's this kind of stuff. Respectful and careful is who we want. We can train you with the information. If you're not teachable, that's tough to fix. When you present, do you say every other word, or maybe when you talk, every other word is like? We have like records at our program for interviews. We're like, oh, this girl said like 38 times in our interview. And our chairman's got like tally marks. He's like, how many did you get? Like, I got 56. Maybe your posture. My wife tells me, she's right, I have bad posture. I need to kind of put my shoulders back a little bit. That's my problem, okay? Maybe when you talk, your speed might need to be a little faster, because we're in the emergency department. I got 2 other patients to see. Come on, give me the presentation. So take your speed, turn it up a little bit, okay? It's like when you're listening to podcasts, do 1.5 speed. Learn to talk that way. That's the way we work, okay? Now, your attire. It's very important, right? You guys look professional today. Good-looking group of people, okay? Never forget my interview. I was up at Virginia. Walked in, group of people. Dr. Brady walks in, big name. Giving his presentation. He's up here at the PowerPoint. This dude walks in with a sweater. In the middle of his presentation, he's late. Without even looking up, Dr. Brady says, you're late, you wore a sweater, you should probably leave. Damn. The way you look sells yourself, okay? If you're cold, don't wear the hoodie. Get a white coat, all right? Look like a doctor. People want to be saved by Superman, not a bumbling reporter named Clark Kent. You need to look like a doctor. All right, so here's a good case, all right? I got a presentation here that I want you to pay attention to. Take some notes on what was done well, what was done wrong. We'll talk about it, see what we think. Okay, Dr. Waiters, I have a patient that I just saw I want to present to you. Taking care of a 46-year-old female, Miss Smith. She is having a chief complaint of chest pain. She has a history of oral contraceptive use. She has no cardiac risk factors in her past medical history. She comes in with a 2-day onset of a sudden pleuritic chest pain that was in the left side of her chest. It didn't radiate anywhere, didn't go to her back. She had no sort of neurologic symptoms with this. She had no exertional component to her pain. She's not vomiting, didn't have any hematemesis or bright red blood per rectum. Review of systems, she's got no symptoms of syncope. She's got no abdominal pain or back pain. She does note that she has some left lower extremity swelling after she twisted her ankle a few weeks ago. Otherwise, normal review of systems. Vital signs, I went and looked through those. Blood pressure's normal. Her pulse is actually fast at 105, and her respiratory rate by the nurse was 20. When I was in the room, I counted, and I noted that there were about 32 respirations a minute. Her sats were 94%, and that was on room air, and she looks a little tachypnic. On general exam, she looks uncomfortable, but she doesn't look toxic. I examined her heart, lungs, and her abdomen. I couldn't find any real abnormalities from that other than her tachycardia and her tachypnea. Went ahead and did an abdominal exam, no signs of abdominal pain. Neurologically, she checked out well. I think in my assessment, I'm concerned that this lady might have aortic dissection, but I think in my history it's unlikely. She has no risk factors for acute coronary syndrome, and it doesn't sound like that's likely, but I'd still like to get an EKG to be safe. I don't feel like this is a Borja. She's not throwing up. She doesn't look toxic appearing. Unlikely this is a pneumothorax, but we probably want to get that evaluated. When I'm left to consider the possibility of a PE, I think she's at moderate to high risk for that with her history. So I'd like to get an ultrasound of her leg, which on my exam showed the Homan sign. I think we ought to get a chest x-ray to further evaluate her lungs, EKG of course, and I'd like to get a CT angio to rule out a PE. Of course, we're going to need to get a full level of labs with her CBC and comprehensive profile to make sure her renal function, hemoglobin are okay, and probably coags, since if she has a PE, I'm going to put her on anticoagulation. At this point, she's headed for admission, unless for some reason all of her tests are normal, but we'd still need to educate her because it sure sounds like a slam dunk PE to me.
Great case, medical student, but what are you wearing?
I'm kind of cold, and so this is a Cookie Monster Snuggie. Yeah. How'd that go? No thoughts at all.
Outside the Snuggie, it's good. Yeah.
Was it okay? Yeah? Okay. That took a little under 2 minutes, okay? And that's, if you've got time, I think it took me like 12 takes, obviously, but that's a pretty good presentation, all right? But again, it's all ruined by you looking like a fool, okay? So, look like a doctor. In closing, Dr. Jones was our clerkship director for a long time, but I think he says it best.
The perfect medical student presentation is short, sweet, and complete.
That's it, baby. Short, sweet, and complete. Don't be afraid. There is no perfect medical student presentation. You saw the diversity from all of the different educators out there about how varied it is. If you want to be an expert, it takes a long time. Who reads Gladwell? Great writer, one of my favorites. Check out this book. It's fun. It takes 10,000 times to really become an expert. I've only practiced for about 12 years, and I'm just now starting to see my 10,000th abdominal pain. I'm just now starting to become an expert at that. It's taken a long time, and your presentations will take a long time, but you've got to practice. If you're serious about doing good presentations, if you really want to do that, you want to make a good first impression, and I think you want to be serious about doing your rotation well, take a selfie. Get the camera out, go in a bathroom, go in an empty room, pop it for 1 minute, watch it, wake up from the seizure you just had, get out of the puddle of urine that you're in, stop sucking your thumb, get over it, it's painful. But you will discover an amazing amount of information about yourself. That's what I'm talking about when I say a self-directed learner. Try the selfie. I won't break for a lot of questions. We have a PD thing, but any quick, pressing questions on the presentation, it's a very complicated subject. In summary, understand the EM philosophy. We care about the worst case scenario, all right? We love the one-liner, become good at it. Rule out the serious. That's what ROS means, all right? Communicate your thinking about these in your review systems and your differential diagnosis. In the end, commit. Humbly commit. Make a decision, man. Next, procedures. Everybody wants to nail that intubation, right? Who's done an intubation on a live person before? There you go. All right, a lot of people. I really think that preparation is a lot more important than placement. Every medical student only wants to know, how do I put the tube in? What they don't think about is the mountain of preparation that should go in to putting that tube in or seeing that flash of blood in a line. Preparation is key. So, failing to prepare, you are preparing to fail. Very important wisdom from Ben Franklin. How do I do that? Who's got a sim lab? Go to the sim lab, okay? The first time you touch a defibrillator should not be during a code. The first time you pick up that central line kit and say, what the heck is all this nonsense? Should not be when you're putting the line in. Go to the sim lab. They can help you do things and say that, oh no, you're off a little bit. Go to the right, okay? Spend some time in the sim lab. Check out the New England Journal of Medicine video series. Who knows about this on YouTube? Watch that. Practice with that. You know, I used to play basketball in high school. I mean, it's like visualizing that shot. You let it go, you see it in the air, you're watching it go through the net. You've got to visualize yourself putting that line in. You've got to watch yourself innovating through every single step. And you got to get permission, right? Got to get permission from the family. You show up, you look like a doctor, you treat the family with respect, you're empathetic, you get grandma a blanket, she going to let you put a central line in her husband? You betcha. All right? Got to get the family's approval. You got to get the faculty's approval, okay? You show up to me, you say, hey, Dr. Wieters, patient in bed 5 needs a central line. I just got done watching the New England Journal of Medicine video series on it. I practiced in the sim lab. I've looked at the labs. There's no contraindication. Consent's on the chart, waiting for it, and I got the kit at the bedside. Do you think I could have a chance with that line? Yeah, I'll give you a chance. Okay, that sounds pretty good. All right? If I got to drag you away from your Facebook site to go do a line, you're probably going to drag you. I'll let you do your Facebook. So, you got to be aggressive, but you got to be safe. Sometimes it ain't the right case. Can never get this guy sats above 80. Can I intubate? Yeah, maybe we should let our chief try that one, okay? So, understand it's got to be safe. Closing kind of things, the million-dollar question. What should we do next with this patient, right? The dreaded, what should we do? Guess what I'm thinking, right? Who loves these guess what I'm thinking questions? All right, I'm going to give you a pearl here, okay? If you're going to write down one thing, the million-dollar answer to the million-dollar question, what should we do next? It's reassess. I want to go check those vital signs again. I hear those can change. I want to go do another abdominal exam. I want to make sure they're not worse. I'm going to go give a PO challenge to that kid and a popsicle. I'm going to go road test that old lady who couldn't walk. I want to go reassess, Dr. Wieters. That's what I want to do next. Okay, you got it? All right. You got to be a student of yourself, okay? The worst thing someone can tell you after a shift is, you did just fine. Great. And you walk off. Okay? You got to go in. You got to say, you know what? I need to work on my presentations. I hear they're too lengthy. Can you help me trim them up? I have trouble recognizing the subtleties of sick children on this children's shift. Can you help me give me some pearls on that? And at the end of the shift, how did I do? Were my presentations more concise? Was I better able to discern the sick kid? Ask for these things and they will be given. When you give permission for feedback, it's going to come back a little easier. When you direct someone to giving feedback, they tend to provide that feedback. That's the only way you're going to get that goodness, and we all need it. CDM curriculum has been mentioned a few times. What should I read in preparation for my rotation? Check this out. Most places use it. It's high yield. It's goodness. Enjoy it. Real quick, a final thing on the art of pimping. How are we doing on time? Okay, I got a few minutes left. I'll talk about this. Who likes to be pimped? Okay, I don't like pimping, but this is a mock thing. If you get pimped and you're in a group, here's how you avoid it, all right? So I'm talking about syphilis here. Watch the girl with the brown hair in the middle with the stethoscope on. So the group is here, and she's going to get called out for a pimping question on syphilis. She camouflages in to lean back behind the taller man. Okay? So the guy in the front gets nailed. All right, next question comes out, and this is the eclipse. You can't even see her, right? Impossible to ask a question to somebody you've never seen. See? All right, she's coming back out of the eclipse, and now if you get called on, have some food ready and stuff the muffin right in the mouth. You can't ask a question to somebody with food in their mouth. That's too rude, right? Yeah, the other guy gets nailed with this question. She's just enjoying the muffin. She's good with it. All right. The last one, sometimes it'll be like a list. Let's go through a list, right? So the first girl gets asked about it. She says it's a rash. You pretend you're meditating about like this important journal article or your patient list, you know, and you're not paying attention because you're so interested in your patients. And then when it gets to you, instead of saying a new answer, you just say the same thing somebody else said. You fake repeat. Oh, but I was just looking over my notes. I didn't know. I wasn't paying attention. I'm sorry. Yeah. So, in the end, you're finally going to get nailed with a question.
You know, Dr. Wieters, that's a
You can politicize it.
question with a lot of clinical relevance, but I think a better question might be, do we need to treat syphilis?
Do we even need to treat it? You know, I can't answer that. That's a tough philosophical question. So, that's how you get out of pimping. All right, any final questions before I take you home with one more story? Pressing questions. Okay, I'll be around. In summary, you guys have to prepare, okay? You're doing that today by being here. I'm proud of every one of you. Take the time, do the work, practice. You're going to need to get permission. You've got to sell yourself to your attending. You've got to sell yourself to your patients if you want to get in there, all right? And then you've got to be proactive. You've got to be in the game. You've got to be at the bedside. You've got to be part of the team. And then pursue feedback. What an exciting time. You guys are jumping from undifferentiated medical students to a focused, specialized emergency physician. What a fun time. Know where your goals are, jump out, take it aggressively, and get there.